So I'm going to go ahead and get started. So we'll start off with a case just to give you a little bit of an introduction as to how we're going to do this. And then we're going to go through some of the basics of understanding acid-base disorders. And then we'll go ahead and do some more cases and try and really break it down and simplify the approach that we use so that we can interpret these acid-base disorders. So the first case is a 62-year-old female comes in with 2-day history of small bowel obstruction, manifesting with vomiting, requiring an NG tube for suction. On exam, she's hypotensive, tachycardic, decreased skin turgor, she has diffuse abdominal pain. She has labs done, and the basic metabolic panel indicates her sodium is 135, her potassium is 3.5, chloride's 85, her bicarb is 25, blood glucose is 90, her BUN's elevated significantly at 110, creatinine's up to 4.5, and she has a blood gas drawn, which shows that the pH is fairly normal at 7.4, PCO2 is also normal at 40. So which one of the following do you think best applies to this patient? So does she not have an acid-base disorder because her blood pH and bicarb are normal? She does not have metabolic acidosis because of normal blood pH. She has a metabolic alkalosis. She has a metabolic acidosis, respiratory acidosis, or she has a mixed metabolic acidosis and metabolic alkalosis. So this is the answer. And like I said, we are going to come back to this question and we will discuss these further and we'll break it down so that we can have a little bit more idea about these. So let's basically start off. What we're going to talking about is high yield information, both for boards and clinical practice, some basic concepts, understanding the nomenclature, how would you approach an acid-based problem solving. So a few questions that we'll discuss in our final conclusions and high points. So understanding some basic concepts. Carbohydrate and fat metabolism generates about 50,000 millimoles per day of carbon dioxide, which is a volatile acid due to its ability to produce a hydrogen ion after hydration with water. So once you have carbon dioxide with water, you form the carbonic acid, which then breaks down quickly into a proton and a bicarbonate. So under normal conditions, the lungs will eliminate all the carbon dioxide produced from carbohydrates and fat metabolism, and thus carbon dioxide has no impact on acid-base balance. In today's day and age where carbohydrates get a lot of bad press, for a nephrologist perspective, carbohydrates are just fine because they don't affect your acid base. Let's talk a little bit, though, about dietary proteins. Proteins, or amino acids, are going to metabolize into non-volatile acids. These include your sulfuric acid, phosphoric acid, and hydrochloric acid. Approximately, a typical American diet generates about 1 milliequivalent of acid or proton per kilogram. You know, in a standard textbook world of a 70-kilo man or a 70-kilo female, that's about 70 milliequivalents per day. The range usually is between 50 to 100 milliequivalents, depending upon your diet, your weight, and your protein intake. So in order to maintain this acid-base balance, the kidneys, the smartest organs in the body, must excrete all this metabolized non-volatile acids. They have to replenish all the bicarbonate that is consumed by the neutralization, and they must prevent all these urinary losses of bicarb. And how much are we talking? We're talking about 4,320 milliequivalents per day of bicarb. So there's a lot that goes in on a day-to-day basis that the kidney needs to do to try and keep this acid-base balance. So you're in sort of electrical neutrality and not walking out generating sparks. This is a little bit of an overview of how this works. Our typical extracellular fluid pH, remember it's a range, but for sake of simplicity, we take the middle of that range of 7.35 to 7.45, which is 7.4. And we generate all this net acid both through metabolism and through the diet that comes through the non-volatile acids we talked about. Now, to maintain this, pH, the kidneys have to reabsorb all the filtered bicarbonate. They have to regenerate this bicarbonate, and then they have to get rid of this acid, which is typically done through 30 millimoles of titratable acid and about 40 millimoles of ammonium. Again, all this is assuming a standardized textbook 70 kilo person. So why do we care about acidosis? Well, because there's both acute and chronic consequences to it. There's consequences into the cardiovascular system. You can have decrease in cardiac contractility and arterial vasodilatation. It's going to lead to hypertension. You have increased risk for dysarrhythmias. There's effect on the respiratory system. When you have metabolic acidosis, you're going to have hyperventilation. There's effect on your CNS. When you have profound respiratory acidosis, you're going to have